Just want to say good evening to everybody. I want to extend a warm welcome and sincere thank you to those of you attending tonight's important conversation in our GeneSight Cares webinar. I'm Dr. Bondi Mansoray, your moderator for this evening. So quick background on me, I received my PharmD from Mercer University down in Atlanta and have spent most of my career working in the psychiatric pharmacogenomics space. Currently, I'm a medical science liaison for Myriad Mental Health based in Chicago, Illinois, serving the Midwest and Great Lakes region. Our panelists tonight bring together a wealth of experience and expertise in mental health treatment and education, and I'm so grateful that they are here with us. We have Mr. Sekou Jones, who is a psychiatric nurse practitioner, currently practicing at Calm Clarity Mental Health in Centennial, Colorado. We're grateful to have you on the panel.
Thank you.
We have Dr. Iverson Bell, who is an associate professor and residency training director of psychiatry at the University of Tennessee Health Science Center. We are honored to have you with us this evening, Dr. Bell.
Glad to be here.
And last but not least, we will be having Dr. Angela Shannon join us. She is a psychiatrist and the medical director and founder of Positive Balance Wellness Center in Atlanta, Georgia. Oh, looks like she joined right on time. So warm welcome to all of our esteemed panelists. Throughout the webinar, feel free, for those of you in the audience, to utilize the Q&A functionality to type in any questions you may have. We'll do our best to get them answered during the webinar. Questions that we are unable to get to due to time constraints will be sent to the panelists and answered separately in an email. So let's get things started. July marks Bebe Campbell National Minority Mental Health Awareness Month. Race, ethnicity, identity, and cultural background have been shown to be determinants of mental health among minority individuals for reasons far too extensive to cover in one program. So tonight we'll focus on a very specific issue that can and is impacting the mental health of both parents and children of color, and that is fear and trauma caused by hate and discrimination. For some parents, the talk might describe a conversation about the birds and the bees. For others, particularly those raising Black boys and girls, the talk means something completely different. This conversation is about the dangers children of color face in their day-to-day lives due to systemic racism, particularly at the hands of those of power. Living with this knowledge can take a toll on the mental health of both parents and their children. I'd like to first start with Dr. Bell. Speaking on your experience as both a parent and a practitioner, would you mind sharing how anxiety and even depression can manifest around the pressure of having this conversation with your children?
Well, it's just like my own experience. Anytime that I'm watching the police behind me, I get anxious, and my son feels the same way. I happen to have grandkids, and they're too young to really be exposed to any of this, but my children have certainly gone through that. There's anxiety around certain authority figures, such as police, that can cause harm. Giving them the talk, I mean, obviously, you need to talk to children about birds, bees, reproductive sorts of things, but unfortunately, there are those of us in this culture and other actually other underrepresented minorities that have to add onto that talk about being careful around certain people because they can do you harm, they can control your life, they can make your life difficult if you don't behave in a certain way. So it's just necessary it was necessary for me to tell my kids about that and them to tell their children when it's time.
Got you. Thanks for sharing. Mr. Jones, is there anything you'd like to add to that?
Yes, thank you, Dr. Bell. One of the things that I've learned as a parent, I have a teen I have twins who are 16 and a half, boy-girl twins. It's just the anxiety that goes with the things that could happen to them when I'm not there. I think we all go through that as parents. I was teaching my daughter to drive, and it was literally the first week she had her permit, and we were stopped by a police officer in a parking lot. And I was really glad that I was there with her, and it, stirred up the fear of like, well, what if I hadn't been there, and how would she have felt? And I think she knows what we've instructed her to do, but it could have been so much more terrifying without me there.
Thanks for sharing, Mr. Jones. And we have Dr. Shannon as well. I was wondering if you can chime in and share your experience with the group.
Maybe had some technical issues.
Yeah, she may still be trying to connect. We'll come back to her. So, Dr. Bell, I'm gonna start off with you. You've attended to both adolescents and adults, and you also work with students completing their residency programs. I'm curious as to what effect discrimination and hate has on the mental health of Black and minority youth.
Big question. The effect on children that I might see in my psychiatry practice, they're fortunately, depending, sometimes they're shielded and they don't have to deal with too much hate, except from neighborhood issues, because Memphis has a lot of difficult neighborhoods, certainly under-resourced, and there's a lot of violence in them. However, the teenagers, when they're dealing with peers of different colors, they have to be careful, again, just in any situation, whether it's teachers or any authority figure, and that anxiety preys on them and keeps them from learning as much as they should. And also knowing that they don't have the same resources that other children do, and the schools are going to be different than the other schools. So hate, discrimination plays a significant part in not just person-to-person interaction, but systemic reaction, like I said, for schools, and with my resident trainees, and interacting between the residents, which are the physician doctors, and their patients. Sometimes, well, I've had some people from different cultures, and the patients may be a little uncomfortable with somebody with an Eastern European accent. So I have to work with that. But I also have to educate, sometimes educate the residents in how to work more effectively with patients so as they don't put them off, to be aware that there's a lot of difficulty between, I call it medical apartheid. So they're very much, the patients don't trust the doctors and the doctors don't trust the patients. So from childhood up, there are different issues that have to be dealt with.
Got you. I think you brought up some really good points. And I know I can appreciate the fact that this is an issue that is being presented in front of our future physicians. So I like the fact that it is incorporated into their curriculum. Mr. Jones, I saw you nodding your head very vigorously. Just curious as to your sentiments on what Mr. Bell was saying.
Yeah, when Dr. Bell was commenting on authority figures and teachers, I was thinking about just how kids, always have to navigate trying to follow the rules and, stay out of trouble. And with children of color, it's just another layer. And one of the things that I think will probably come up is that you can almost never prove why someone's doing something. So like, can you prove that the teacher is showing bias or picking on a particular student? And so I think that makes it even harder for kids, because I can think with my kids, I want them to follow the rules. I want them to be respectful to their teachers. But there were times when I thought, well, that's not fair. And when they're young, it's hard for them to advocate for themselves. So it's, yeah, I think that that's just another, piece. The other thing I would share, my daughter is just, her social intelligence is off the charts. And she said to me, she said, when the other students, because she and her brother are like 2 out of maybe 4 Black students in their K through 12 school of about, 600 kids. She said, well, when other kids see the security officer, the safety officer, they're thinking, oh, hi, Mr. So-and-so. She said, I'm thinking I need to keep my hands visible. So that really got my attention.
That is extremely powerful. And I like the point that you guys are sort of underscoring some of those microaggressions that sometimes get forgotten about. We hear about so many insidious instances of young Black children, male and female, getting sent home for wearing their natural hair. So I like the fact that you kind of brought that to the limelight. And it seems that we have Dr. Shannon with us now. How are you doing, Dr. Shannon?
Doing well.
Glad to have you here.
John,
Well, we were just sort of discussing the effect of discrimination and hate on the mental health of Black and minority youth. Just curious if you wanted to chime in with your thoughts or experiences on that.
where would I start with the experiences and the thoughts about it? Of course, being an African American, I've experienced them personally, and being a psychiatrist, I've had to treat patients that, have experienced these things, whether we're talking about children or adults. And it's, always a interesting feat to have.
Got you. And, you being a psychiatrist, a healthcare provider, have you had to give a version of the talk with your patients or even coach parents on how to have that conversation regarding the influence of hate and discrimination on the mental health of adolescents?
Being a child and adolescent psychiatrist, and also being a parent and an active parent, I've had to give the talk. I've had to parents ask for, coaching on how they should give the talk, if they should give the talk. I've had parents as patients who have expressed frustration because they thought that their child at whatever age was too young to get the talk. And then I would have to explain to them that I know as parents, we want to shield our children, but if they are in the world, unless they live in a bubble, they cannot miss whether it's overt or covert, something in them recognizes that something is different between the treatment. I had a pre-K kid express to me that they felt like the librarian was being racist. And I said, well, you don't want to put words into a child's mouth. So I said, well, what is racist? So they couldn't give me a concrete definition of it. But what they described was, well, when we go to the library every day, the kids who don't look like a few of us, and there were only a few African American or children of color, when we would go, if we would play with the computer or do things on the computer, the librarian would make her face like this and talk very rough to us. But she never did that to the white children, Caucasian children. And so that if I thought about what racist was like, that seems racist to me. And that's from a 6-year-old.
Yeah, children can be quite insightful sometimes. Dr. Bell, do you have anything to sort of add to your experience and how you educate either your patients or parents about the talk?
Well, I have to tell parents that they have to be aware of what's going on in their school. My son was learning world history, and we asked about Brazil and some other countries. It turned out that world history was only the Northern Hemisphere. Nothing was included from the Southern Hemisphere. Brazil wasn't important. Most of Africa wasn't important. I don't know if we ever really got through to the teacher, but we made it clear that this was an important part of the world's progress, the world, how people interact and so forth. So when you talk about hate, when I hear the word hate, I think about violence, but it's not so much violence, it's these subtle things that happen. I mean, obviously there are problems with the police and some other security guards and other those kind of authority figures, but it's the day-to-day activities where, you know, obviously there's being watched in stores, in the library, as Dr. Shannon pointed out, things like that where you're made to feel uncomfortable but can't quite put your finger on it. Those really are the things you have to talk with your kid about and explain that you know, some people just feel differently, and you have to build the kid up to make sure that the child understands that they have worth and they're worth just as much, and they should be trusted. And if the teacher doesn't trust them, it's the teacher's problem, and the parent is going to back up the kid.
I like how you put that. It's very important to have these conversations with children, to be, you know, open and honest, but at the same time, you don't want to sort of break their hope and sense of self. So I think you brought up a really great point. Mr. Jones, do you have anything to add to?
Yeah, I was thinking about how, you know, so much of childhood, if not maybe all of it, is about learning. And, you know, kids are looking to adults, depending on their age, you know, they look at us differently, but they're looking for help interpreting their environment. And so, you know, one of the things that that Dr. Bell was saying about dealing with teachers and just, you know, to help the child have self-worth, it's important for us to talk to the kids to help them separate what's really about them or potentially about them versus it's really not about them. You know, it's about people's preconceptions or, you know, because I think all kids will say, well, I think the teacher hates me. And I don't know what happened in the classroom. I do think that we need to be engaged. As Dr. Shannon said, she's, you know, a highly engaged, active parent. But, you know, as Dr. I think as Dr. Shannon was sharing about the library, about the pre-K kid, yeah, just helping the kids interpret their experience. And we don't want to put words into, you know, the mouths of teachers and authority figures. We also, I think over time, I think we instill pieces of helping our kids in our practices and in our families understand that it's not a good person, bad person thing. Someone can be very caring. You know, some of the teachers that my kids have had, I mean, we're really fortunate to have some really great schools, but a caring, sensitive teacher can still say something that is really offensive or that's loaded with meaning that they weren't aware of. So it, you know, helping kids interpret that and to know that it's, yeah, things will come up, and to also learn how to talk to the teachers about it according to their age and what they choose to, you know, say. My daughter has sometimes told me, don't talk to my teacher about it. I don't want to, you know, she's like, I think the teacher may kind of take it out on me, and I just don't want to push the issue.
Really good point. So Dr. Shannon, I have a question for you. Are there any best practices in helping the healthcare providers on the line as far as them recognizing trauma and re-traumatization. So for example, if a patient's concerns are due to past lived experience, whether that repeated trauma is experienced in person or, for example, through the news.
I think it's critical, and is one of my soapbox items, if you will, where, because I found so many patients where they will come to me with a diagnosis, but for whatever reason, and this is not like laying blame, if you will, on the provider, but just asking providers to be more intentional about not leaving out trauma, or asking it in a way that a person of a different culture may understand what they're saying. Because if you ask, a kid from a certain place of a certain culture, have you experienced trauma? Well, for them, trauma may mean being in a car accident. So they may say no. But if you ask them a question, tell me about what happens in your neighborhood, which is a broader question, it's no telling what you may hear. If you ask them more specific questions, I remember being in training and speaking to a young lady that I felt in my gut had been experienced a sexual trauma, because, and the clue for me was that she ran away from what everybody kept calling a good home 14 times before she was 14. And I said, I'm new into this MD thing and this child psychiatry thing, but something about that makes no sense. Who runs away from good? But again, like Dr. Bell pointed out, and Dr. Jones, you don't want to put words in somebody's mouth. So for 14 days, I would ask this question, that question, the other question. Finally, it came down to us being in a group that had nothing to do with sexual abuse. It was a chemical dependence group that had all teens, and the main facilitator, who was not me, just happened to be absent. So they asked me to co-facilitate. It was really a divine intervention, because nobody else would have known how to weave in something about sexual abuse in a group that was focused on chemical dependence. But anyway, they were just, the kids were talking about, what kind of drug experiences they had, encountered. And then finally they moved it around to, well, the worst thing about doing drugs is that people end up touching you or doing things in an inappropriate way. And the young lady that I'm referring to asked the question, she asked, what is inappropriate? And the more experienced facilitator was getting ready to answer her. And I asked, can I beg of you, don't answer. Can you let the other peers answer what is inappropriate touch? They came up with something I wasn't even thinking of. Finally, the young lady bolts from the group, bursts in tears, and locks herself in a bathroom. I finally convinced her okay, so if you won't come out, can you let me come in? And she did. And I asked her, why was she sobbing? And she finally revealed that she had been sexually abused, but she didn't know that what was happening to her was sexual abuse, because she thought that sexual abuse was something that happened between two different sexes. Like, I'm a girl, but it was my grandmother who was sexually abusing me in front of everybody and disguising it as a tickle, but it really wasn't a tickle. She was squeezing my breast in an inappropriate way. And even when I would ask her to stop, she wouldn't. And then she went from that to discussing other things that, when you first say sexual abuse or trauma, may not be high up on the list. And that's just an example of how you may just have to ask it upside down and sideways, or just find yourself in a situation where, you know, it can evolve with the help of others and not you.
Very powerful story. Thanks for sharing, Dr. Shannon. You definitely included some really great tips on how our practitioners or parents in the audience can start to have those conversations with their children. Dr. Bell, so I know you are in the academia residency setting. In those programs, have they evolved to address the impact of discrimination and hate on families of color? Or do you see gaps that have yet that are there where these issues aren't being addressed?
Well, having these issues addressed through all these diversity initiatives is, for psychiatry residencies, is still kind of a new thing. Many programs touch on it. We're figuring out how to address it, but generally it isn't well addressed, other than to say you should pay attention and listen to other people and try to figure out what they're really saying, and what is, as Dr. Shannon was mentioning, an adverse childhood event or adverse adult event. We meaning all the training directors, have to take the initiative to get other people to teach the right thing. I'm talking about my fellow professors, to teach how to deal with people of different cultures, and teach the residents. We ourselves have to work with the residents to teach them to respect each other and the differences in each other.
Really good point. Before I move on to the next question, I want to read a question that was, or a comment, I should say, that was inputted in our Q&A box from a Saritha Stevens. As a psychiatric mental health nurse practitioner working with underserved population at McIntosh Trail CSB in McDonough, Georgia, you are faced with clients who are not aware of their racist views and biases. As providers, we have to be advocates for our children as well as our parents. I have to talk with my parents on a daily basis in the presence of my younger clients. Parents need reassurance from us as professionals to validate their concerns with racism and its effect on their children. Thank you for that comment. Do any of the panelists have any words in response to Saritha Stevens?
I must. My wife is from McDonough, from an area that used to be known as Blacktown, for obvious reasons. So she's very much aware of the progress the town has made, and still the issues that we still have to work on. So I'm very much aware of McDonough. And my wife went to Mercer as well for pharmacy.
Really? Okay, well, we'll have to talk later about that. I didn't know that.
Well, and one of the things that I know is powerful when you have kids is to have somebody else say things, even if you've said it to your kids. Sometimes you need another adult, or especially someone who is regarded with authority. And I don't think of myself as being more expert or more important, but I do recognize, I mean, I do have areas of expertise, but I recognize that I have I'm in a good position to support the parents and to validate something they need to hear sometimes to validate, how their kids are responding to something. So it's just important for us to recognize that we do have a voice that can, sometimes be heard differently.
And you, speaking of that, no pun intended, those who are in the programs who are of color, it takes a certain degree of boldness to speak on these things when they come up. My experience when I've been put in for me, it's more uncomfortable to remain silent than it is to point out what is just so obvious. But in doing that, I also broaden my horizons, because in one instance, when I confronted a peer about using the word niggers in a presentation, and another one about using colored in a presentation, and another about using the word boy to describe a 57-year-old man, I was apologized to after that encounter, and this peer humbly and sincerely, I feel, explained to me, I didn't know that those words were offensive. I was raised in way South Georgia where it's okay. I said, well, it's not even okay in South Georgia, it's just done. And so I'm glad to help you understand. And I was asked a valid question. Well, what about the NAACP? Because that's for colored people. I said that name was derived at a time before even some people of color could appreciate that was thrust upon us and that we didn't have to accept that. And I said, so it's kind of like the N word. Some people can say it, and even now people of color don't really want you saying it. But for sure, if you're not of color, is totally unacceptable.
That's really good points. And sort of in that same vein, I have a question for Mr. Jones. So some non-minority parents are unaware that the talk takes place among parents and children of color. Could you please talk about self-disclosure as a tactic healthcare providers can use to educate the parents of non-minority children about how privilege exempts them from the additional fear and trauma Black parents must manage?
Sure. An interesting piece of this comes from something a young white male client said to me. He probably didn't come up with it, but he said, privilege is anything that you can dismiss as not being important. So he said that if you say that being male doesn't really make that much of a difference, then you have male privilege, because you're putting yourself in a position to render judgment over whether it matters or not. Well, money is not important. Well, that means that you perceive yourself as having a wide range of options. And so, I'm sorry, you were asking about, I got off topic there a little bit.
Yeah.
Dr. Bond.
Just self-disclosure.
Oh, self-disclosure. Yeah, so so another piece of this is that I recognize, because, so I have a small private practice. It's a solo practice. So it's just me. I do everything. And because it's mine, there is kind of a perception that I think my clients have that it's, that I'm in a position of privilege because I own a practice. I get to make the rules. I have certain authority. I mean, we all write prescriptions. That's a certain authority. And so when I can share with them that there are things about race, and that there's even a fear that I experience I think it can help them to understand that they can't discount the, the anxiety or the depression that may come with these topics just because I'm in a position of privilege, which I am. I have educational privilege, I have financial privilege, but I still get scared. Like Dr. Bell said, I still get scared when I see, a cop behind me. I've had to explain to some of my clients, and it, there are reasons why I bring it up, but I've had to explain to them that, yes, I'm very fortunate to live in a very desirable neighborhood, a lot of working professionals, but I don't go out after dark because I don't feel safe in my neighborhood, which is, I want them to understand there's kind of an irony because I've lived in neighborhoods where there wasn't as much wealth really, and where people might not be prepared for the potential that I have education, that I'm articulate, but I didn't feel like I stood out. And whereas in my neighborhood, I do.
Really, really insightful stuff that you've shared with us. I think that self-disclosure is key, given that, recent events like George Floyd, Breonna Taylor, Daunte Wright have really sparked an interest in various institutions to better understand and serve minority populations. So that self-disclosure is step one. I have a question for Dr. Shannon. So how are the dynamics of treating similar or different among today's modern families where multicultural children are being raised with parents of differing backgrounds?
I don't really think that there's a difference, except that we're just confronted with things in a quicker amount of time, in a shorter amount of time, because of social media and the instantaneous, devices. So you just know about it sooner, but I really don't think it's changed, over time. Laws kind of shifted things a little bit, but as soon as those laws were removed, I know of medical schools that nobody of color was accepted immediately after that was removed, like nobody. And that's incredible, but it actually really did happen that way, saying that, everybody should be playing on a level field. Well, how can you play on a level field when some folk weren't even on the field? Because of the lack of privilege, the lack of economics, the lack of education, the lack of exposure, and we could just make a whole long list of things. So the only difference would be that it's 2021, but pretty much you would have to still deal with it and help your patients to appreciate it. Because I think that what I know because I was taught and educated by mentors who weren't afraid to speak about these things, like Francis Cress Welsing, like Carl Bell, like Iverson Bell, like Alpha Stewart, like Bill Lawson. I have gone to places and practiced medicine where nurse practitioners and MDs alike, just pick a provider, really earnestly had no appreciation that people of color don't need more antipsychotic medication because they are bigger and darker. Actually, it's the reverse, because a lot of times they don't have the enzymes, to metabolize these medicines. So actually in giving them more, and you're wondering why they're tearing up the place, that's why. Because it's still on board and that doesn't feel good, but they don't know how to tell you that I'm experiencing akathisia. They don't know what that is and if you're not in tune enough to, first of all, know that it's probably not the best care to be giving somebody 2 injectables, long-acting injectables, and 2 atypicals, and then just sprinkle a little bit of a first generation in there for effect. They may not even think about akathisia as a reason for why the person is behaving the way that they are, because it's not really a behavior. Now they're physiologically sick from something that was given to them to hopefully help their emotional or mental struggle. And I have too many examples of these things for this short 1 hour presentation, where I was just thankful that culturally I happened to be in the place at the time when the nurse was regarding somebody's behavior as quote unquote acting a fool. And I said, it's just something else there. I don't think it's just acting a fool. And thank goodness the attending who was not there listened to me as a resident instead of listening to seasoned nurses who were not of color, who viewed this 7-foot-tall young African-American man as acting a fool, and he actually had neuroleptic malignant syndrome. And had not my attending listened to, I said, it's something else. And I think I've seen it before as a medical student. I think it's this. And ordered the labs, and they were critical, in the critical range. The person survived it, but oftentimes that particular syndrome is deadly if you don't recognize it and do something about it quickly. So.
Well, I'm glad you spoke up in that situation. I have a question for your mentor now, Dr. Bell. What is the best advice healthcare providers can share with Black parents and children to help them cope with and withstand the challenges presented by systemic racism and the toll it takes on mental health?
Well, parents need to listen to their kids. I mean, serious listening, not just to the day-to-day stuff that happens, say, in school, but what is really going on. And of course, need to make sure that the kids are able to hear what the parents are going through. I am one of the few faculty of color here, and that's not unusual. There aren't that many Black psychiatrists, period, aren't that many people that are teaching. And as far as being in charge of training, there are very, very few. I formed a group of about 50 training directors, Black training directors. And it's interesting that we talk about some of the same things that that kids go through, being ignored when we say something, even if the chairman of the department may ask a dean for something. And it's interesting that one group of people will be listened to, but he or she is not. And us talking with each other is very, very reassuring, because we can't talk with our buddies about this. We don't have any real buddies here. But talking with somebody in this group, online group, is very reassuring to know that, you know, we're not making this stuff up. We are actually going through something. And I mean, the kids go through some of the same things, especially if it's a kid of color in a majority school. They go through being ignored or being accused of. My son was in a classroom where he was sitting off to one side. He was paying attention, but this other child kept talking to him, and my son wanted to move because he wanted to listen, which is a strange thing for a kid in elementary school to say, but he wanted to listen. This other kid kept talking to him. And of course, you know who got in trouble for talking, and it wasn't the other kid. So fortunately, we're very involved in PTA, and we made a point of actually making sure that he was listened to, and he was requesting to move, and the teacher wasn't paying any attention to him. So the same thing happened to kids that actually happened to us as adults. And it's often kind of subtle. I mean, nobody called my son any names, and he couldn't, of course, call the teacher a racist. But, you know, if there's communication between the kids and the parents, they can commiserate with each other. They can reassure each other they've been through this and how to deal with authority figures. And, you know, if necessary, the parent can support the child, go to school, talk to the teacher, talk to the principal or whomever. It's often very, very helpful. So again, getting back to the same old thing, communication between parents and kids, whether the parent is a single parent, an aunt or uncle or grandparent talking to the kids, there needs to be communication with some adult figure that will listen. So it doesn't have to be two parents. It can be one parent. It could be an aunt or an uncle, but there needs to be somebody that can listen to the kid, help the kid navigate through all this and grow up with a little strength, knowing that they're individuals with value.
I think that's a really good point. I know for me personally, having a strong support system has been the reason why I've been able to make it this far in life, and dealing with all these, challenges in today's world. As a child, that support system is just as important as an adult. So I'm curious to hear, Mr. Jones, what sort of tips or advice do you have for the practitioners in the audience?
So I was thinking about kind of the question of how to support your colleagues, and like, is there something you should read or something you should know? And I thought about how pretty much with anything where we're motivated to learn, we look for those opportunities ourselves. And we also, I think part of the motivation has to be the belief that it's relevant. So, I like examples, and I was thinking about how I live in a very nice neighborhood. I feel acutely aware of my privilege. I'm very thankful for the opportunities I've had. And people are really nice to me. They seem to keep their jobs. They keep the area clean. I've never seen anything rambunctious in my neighborhood. And I thought, if I just looked at it in terms of my personal experience, I might say there's no alcoholism. There's no alcohol abuse in my community. People are good and they're nice and they're responsible. And none of my friends abuse alcohol, and none of them came from alcoholic households. But I know as a clinician, I need to ask those questions of my clients. I know that I can have colleagues who grew up as children of alcoholics. I can have colleagues whose spouses or partners are alcoholics. So I know that there's a reason for me to learn about it, even though I may not think it's an issue. And that's what I want from my colleagues, is for them to see it as relevant to them. It's not just relevant because they know me, it's relevant to them. And, another thing that I think has fortunately come out a little bit more in the last, or I've seen brought to the forefront, is the role of being an advocate. When we have privilege, to advocate for those who don't have the privilege that we have. And so I know that there are some things that my colleagues could say what I say, but they'll be heard differently. It'll be taken more seriously. For Dr. Bell, for Dr. Shannon, when you have colleagues who aren't of color, who, maybe they say, no, don't ask me, ask Dr. Bell. He's the one who really knows about this. Or, Yeah, I heard Dr. Bell saying this the other day, or, I noticed Dr. Shannon was with this patient and this happened and that's not right. It's nice to have other people seeing that they have a stake in it and being proactive in learning.
Dr. Shannon, any tips for the audience? Best practices?
Best practices, always ask one question too many.
I like that.
Because that'll be the question that will save your patient probably and save you grief in the end. Sometimes less is more. Don't be afraid to ask the question because you're trying to anticipate the answer that you may get. Because if you're able to ask the question, I'm a spiritual person, I don't want to say religious. If you're equipped to ask it, you'll be equipped to handle whatever comes out. Having worked also in corrections, a lot of the patients there deal in shock and awe. But if you meet them on not such a pious, superficial level, you usually get a better response. Like being an exhibitionist, and then you tell them, now, would you do that to your mother? I'm a mother of a son, so, and they don't ever do that again. Sometimes it really takes you stepping outside of the nice, neat little expected place to get to a place where somebody will allow you to help them. I appreciate this forum to be able to talk about these things. I appreciate Myriad for putting it together and some of the key figures that put this together, because they have been very transparent in saying, well, I didn't know that, or I never thought of that. And it just takes a whole lot of those from a whole lot of different people. I have one colleague that's a child psychiatrist that got put out of her neighborhood because she was treating Black kids. Now in New York, as a psychiatrist, how many patients can you see at a time? And you're not holding groups, one. So how is that going to be disruptive to the flow of traffic in a neighborhood? It's not. And this patient, this colleague was comfortable enough with me to call me to ask me, do you think that my neighbors are racist? You ask, if you ask and you feel it's probably so, because I pointed out that in New York and other places, patients are seen in the homes of the psychiatrist because of space issues. You can't have your brick and mortar. This was before all this Zooming and everything. So yeah, just ask one more question, be more informed, ask questions of your colleagues, and say, you can preface it with, I don't intend to offend, but I'm trying to learn. I have a colleague that called me, I hate to use you as my authority on Blackness. I say, well, I would be more of an authority than you would, so it's okay.
I hope everybody's taking notes. You guys are dropping some knowledge tonight. Yeah. So I want to close tonight's program with having each of our panelists offer a challenge to the clinicians in the audience. A recent Ipsos study recommends the following: hire a multicultural team or speak to a hiring manager about the importance of multicultural hiring. Get comfortable with being uncomfortable. Stop using the white experience as the benchmark. respect experiences, and validate feelings. And lastly, explain the roots or truths of health disparity and racism. Starting with Dr. Bell, what is one thing healthcare providers can do tomorrow to stem negative mental health impacts associated with racial hate, trauma, and fear of violence?
I would get the most difficult question.
Don't worry, everybody's gonna get it. You're not alone.
Can you repeat that? Maybe rephrase that question. I'm not sure I'm hearing it right.
Yeah. So pretty much we want to challenge clinicians to walk away from this webinar and have them, maybe start having these conversations with their patients or speaking up about some of their experience that they may have had in the workplace. What tips do you have for them, or what challenge do you have for them so that they can sort of help to alleviate this racial hate, trauma, and fear of violence that people of color experience?
Well, my challenge to my residents, which kind of fits the bill, is to, when they have a patient of a different race specifically, ask them how they feel about having a doc of a different race. And doctors typically will ask that, phrase something like that. So they're asking questions to find out what the other person's experiences are like. That's the basis of a good interview, is to find out information, not that you presupposed, but information that you can only find out if you're having a good conversation with somebody. So as Dr. Shannon said, ask one question too many. I like that. You have to, the resident, the doctor needs to ask questions, get to know people that aren't like them. I mean, go off on one of my little soapboxes. If you look at most corporations hire people that fit a certain image, whatever that image is. And the CEO is going to pick somebody to follow him that acts just like him, promotes the same kind of atmosphere. So that's where the good old boys network comes from, because they all know each other. And it used to be just all men that knew each other from country club and whatnot. But if you're talking to other people that aren't like you, people that are outside of your country club, you'll often find out a lot more interesting information that will benefit you in one way or another, whether it's monetarily or whatever. But if you keep asking the same people the same questions, you're going to get the same answers. That won't do you any good.
Got it. Mr. Jones, your challenge for the audience and how they can put a stop to these challenges that we face in the Black and minority population.
I think that piece of being comfortable with being uncomfortable, also comes together with asking questions. Because if you ask a question in such a way that you really want to hear the answer, that helps to change the dynamic. I have learned so much from my patients over the years. I came out of school not knowing any Spanish, and worked in predominantly Spanish-speaking communities for the first, probably 7 of the first 10 years. And I noticed how the people that I saw were okay with me saying, well, they tolerated me saying some really dumb things, even linguistically using the wrong words, because they could see that I really wanted to hear the answer. They could see that I was okay with being corrected when I said something that wasn't appropriate or true. And so I think, and that's a position of discomfort, because I think part of the medical profession is you want to get things right. I mean, it's not, you don't want to say like, oh, wait, I meant, I didn't mean Prozac. I meant, I meant Abilify. Like you want to be thoughtful, So we don't like to make mistakes, and our work is very precise, and legally you want to get everything right. But when you're dealing with people, you have to be okay with making mistakes and being uncomfortable. You might ask a question and they might get mad at you, or they might start thinking things about you that aren't true. And that is exactly the experience. I constantly am concerned that people are going to misperceive me, label me. They're going to think I'm angry when I'm not. And so if if you're willing to be uncomfortable and know that you might be misperceived, people might hold a grudge, they might not trust you, they might laugh at you, then you're actually doing something right.
And last but not least, Dr. Shannon.
Is there enough time left? What else can I say? Just, again, be willing to, if I could issue a concrete challenge,
Yeah.
I would challenge people who are not brown people to listen to or research works of researchers like William Lawson, who point out why you can't assume that because everybody else can take this much of said medication that it's across the board, not taking into consideration that pre-COVID, people of color, any color, were not tripping over themselves trying to be in studies. So how can you really, really say that all of this, this is what you expect? Even with my patients who are not of color, I will tell them, I'm going to tell you the most lethal side effects of the medication and the most experienced side effects of the medication. So unless you want to sit with me until tomorrow, they list anything that anybody has ever had. And really, I caution you about, if you're that kind of person who is gonna, if I tell you your right arm is gonna possibly fall off if you take this medicine, you're gonna call my office tomorrow and say, my arm is gone. Caution, don't read all of that. Just know the thing that's gonna kill you and the thing that might cause you some discomfort and tell you how to do. To read the works of these people who specifically sought out to find out how medications, therapies even affect people of color. Even in my training, one place trained me that I should not tell a patient anything at all about myself, nothing. Just be a blank sheet, just a blank. That did not work with any of my patients. They needed, and you can disclose something without being inappropriate. Well, you don't know nothing about being poor. Oh yes, I couldn't even afford the O and the R to finish off the word. But this isn't about me, it's about you. That's just enough without giving them details of where you were raised and by whom and all that, so that they know that yes, you are human. So just be human, be willing to ask, be willing to be asked, because to be honest, some of my colleagues don't want to be asked. And maybe I shouldn't say that because that might hinder those who may want to ask, but pick out somebody like some of the people on this panel who don't mind. That's why I teach. And I specifically tell my residents, medical students, nurse practitioner students, because they'll ask, why is it that you are one of the few doctors who is not an academician who does this in this way? I say, because I love my folk and I love folk. And I want to tell you how to get it right, because I'm not going to be here forever. So anything that I can impart on you, like the Dr. Bells, McCoys, and just Lawsons and Newkirks and Hugheses and all the doctors who poured into me so that I could have a chance at getting it right. That's why I do this. Because somebody did it for me, and I pride myself on not being the average bear and doing it like other folk, but doing it correctly and doing it to a higher standard than what managed care wants or expects.
Very powerful stuff. Thank you, Dr. Shannon, for sharing. I want to thank not only our esteemed panelists for joining us tonight and sharing their wonderful experiences, but those of you in the audience for taking time out of your evening to jump on and ask some questions in the Q&A box. We appreciate you all, and we hope you all have a wonderful evening, and we will be in touch with those additional questions that may not have been answered. And again, thank you to Mr. Jones, Dr. Shannon, and Dr. Bell.